Hello, and thank you to Julio for inviting me and for the moral support that the BC Centre for Excellence in HIV has given us throughout dealing with this epidemic. I'm speaking on behalf of the numerous people and organizations that responded to the epidemic in southern Indiana. Basically, this epidemic is in the United States. It's in Indiana. It's a state that most people, even in the United States, don't know where it is until last Friday. We are, by population, about 6.6 million. It's the 16th largest state. It has 92 counties, but it is the 50th in funding from the CDC and the 47th in funding from HRSA, which are the major federal funding sources for health. Scott County has a population of 24,000. Between 2004 and 2013, it had 5 HIV cases. Austin has a population of 4,000. It's 19% of the population is below the poverty line. 9% are unemployed. It ranks 92nd of 92 in health indicators, including life expectancy. And there's a drug abuse rate of 10% in the population. I will also note that in Indiana, until recently, needle exchange was illegal. So I'm going to talk about the timeline for the outbreak. In November of 2014, the first case of HIV was noted. By mid-December, the number of cases equaled the number that had occurred in the 9 prior years. By mid-January, a cluster of 8 cases were linked to Opana, oxymorphone, a drug that is legal but was being purchased on the black market. This instituted an Indiana State Health Department investigation on January 23rd, and the establishment of a local incident command in February. The CDC became involved in March, and on March 25th, my division was asked to help to respond to the emergency by providing HIV care in Austin because the residents could not travel because none of them had driver's licenses or owned cars that were in this population cluster. And so, despite the fact that they had been referring people to services, only approximately 2 people had been linked to services by that time. The governor declared a public health emergency on March 26th. The advantage of the public health emergency, aside from providing funds to address the epidemic, was the fact that needle exchange could be legal if requested by a county. Our HIV clinic opened on March 29th, and needle exchange started on April 3rd. A community one-stop shop was developed that would provide needle exchange services and other services that I will discuss. Early in the epidemic, a phylogenetic analysis was done of the virus that was being transmitted in the community of the first 57 specimens. What it identified was a single huge cluster, 55 out of the 57 transmissions, that with avidity testing appeared to have entered the community within the past 6 months. There was also a cluster of 2 patients that appeared unrelated to the current injection drug problem. Of note, within our population, people were injecting 2 to 20 times a day and sharing needles with up to 20 individuals, with the mean number of needles shared with 9 other individuals. The response was multi-institutional. The community became involved, the local health department, local health providers, the Indiana State Health Department, other state agencies, academic institutions such as mine, NGOs, federal agencies. In part, what we had to do for these individuals was make sure that they had health insurance because we do not have a national health care system. And since these individuals were unemployed, they did not carry employer insurance. In order to have health insurance, you have to have a state identification. And many of these individuals did not have state identification because they did not drive, and our major identification in the United States is a driver's license. So a one-stop shop was set up that included an area for vital records to obtain driver's license or state identification, insurance enrollment in our state health care policy, which is Healthy Indiana, which had started recently before this epidemic occurred. We also had access to addiction and mental health services there, immunization, HIV and HCV testing. The needle exchange program was with the one-stop shop, and referral to HIV care, which was established in the primary care physician's office in Austin. The goal of this entire movement was the epidemic control as well as optimal patient care. A simplified algorithm was developed. We chose to address this as we addressed the epidemic in Kenya, where we've been involved for many years, and provide an algorithm based on the US guidelines for HIV treatment. Patients enrolled in their insurance program, they got their laboratory tests, a physician assessment and counseling. Their labs were drawn. If they were HLA-B 5701 negative, they received Triumec, one single pill a day. If they were positive or had hepatitis B, they received Triamune and dolutegravir. They were supposed to return 2 weeks after initiation of therapy for adherence and side effects monitoring. At the current time, as of June 2016, there were 191 patients eligible, HIV infected. There are a total of 197 patients diagnosed. However, 2 are deceased and 4 moved outside of jurisdiction, so we cannot follow their viral loads or treatment course. 92% had engaged in care as defined by our state, which is either having a viral load or a CD4 count. 73% had engaged in care coordination, and 66% had been prescribed antiretrovirals. 60% were virally suppressed at that time. We are currently at a total of 198 cases. 1 case was pending confirmation as of this report. The majority are infected with hepatitis C. The median age of the population is 34. It's predominantly male, predominantly white. They have done a very good job at contacting those who are exposed, and we've got a contact tracing and offered testing rate of 89%. Currently, Austin's prevalence of HIV is 4.6%, which is some of the highest in the country. So I'd like to acknowledge all the responding organizations, and particularly I'd like to acknowledge the individuals who helped with this presentation: Dr. Jerome Adams, our Commissioner of Public Health, Dr. Jennifer Waffle, who actually rolled up her sleeves and helped out with direct patient care, Dr. Diane Janowitz, my junior faculty, who actually initiated the HIV clinic in Austin, Patrick Miller, who actually started our PrEP program, the primary care practice that loaned us space, and the county health officer, Dr. Kevin Rogers. And particularly, I'd like to thank Dr. John Brooks and Dr. Phil Peters from the CDC, who helped lead the response to this epidemic. Thank you.